Thank you very much, and I appreciate the opportunity to express to you a few of my own thoughts on where we're heading in terms of healthcare delivery in this country. We like to say that we have a great healthcare delivery system in this country, and if you compare Australia with the UK and the USA, you are entitled to say that. But to sit on your laurels and say, well, we've got a better system than those two countries, therefore we have no issues, is completely ignoring the facts. I'm going to choose 6 issues, and I'm not suggesting these are the only issues, but they are 6 important issues that we need to consider when we're considering our healthcare delivery system into the future. We've already heard tonight about government finances, deficits and debt, and you couldn't consider the healthcare delivery system without considering the complexity of the financing of our system. We need to talk about Medicare, public hospitals. Training and standards are something that's fundamental to we VMOs that work in the public hospitals, and the community needs to understand the importance of maintaining standards. And that's the emphasis I want to put on that subject. And we look at regional services. And finally, a couple of words on research. Well, we're talking about a system that in financial year 12-13, we spent $147 billion, 9.6% of GDP. The percentage of GDP hasn't altered that much in the last decade, although it is slowly going up. What we need to understand, though, is 100 billion of that comes from government, so there is 47 billion that comes from non-government sources. The feds produce 60 billion and the state government's 40 billion. And you'll note the non-government sources actually provide more money than the state governments. By non-government sources, we're talking about we individual patients. We contribute to the healthcare delivery system with our wallets. The health insurance companies are providing an enormous amount of money into the healthcare delivery system, and so every year they go to the federal government asking for a rise in the premiums. Before you sneer at them and say they're trying to put their hand in your pocket, you need to understand they are providing an immense service in terms of that $47 billion that they made a large contribution to provide the healthcare delivery system of the country. But there's workers' compensation, compulsory third party and research grants make up the non-government sources of revenue. We can't talk about it all unless we do understand that the medical services and the pharmaceutical benefit scheme constitutes nearly 60% of the outgoings from the federal government. Currently $36 billion. Now that's what Medicare is paying or contributing towards. The problem is that the community believes that the Medicare levy pays for that $36 billion. Well, the Medicare levy is raising currently about $10 billion, and the medical services and the PBS is currently $36 billion. So the community needs to understand that if the government's debt and deficit issues are going to mount, as we've already heard tonight, then you have to look at Medicare. The community believes Medicare is a great system, or perhaps it is. But it's not a great system, I'm sure an economist would say, if it raises $10 billion and spends $36 billion. Now the federal government also provides money for the hospitals under special purpose payments. So we get to the confusing situation of 2 levels of government financing hospitals. The state government does spend money on public hospitals, obviously, but it also spends money in community services and public health. The non-government spending is principally on private hospitals, but it also spends money on medical services. We surgeons charge our patients. The patients get some money back from Medicare and they get some money back from insurance companies, and so the non-government spending is significant in terms of the overall spending on healthcare delivery. The insurance companies also spend a lot of money on aids and appliances, and also on medication that's not covered by the pharmaceutical benefit scheme. So, with that sort of overview of the finances, the summary of that is it's very complex. And with a complex base, if we're trying to make improvements, make more efficiency in terms of how the money is raised and spent, you're starting with a very complex base. The public hospitals are 32% of total recurrent expenditure. Federal government provides 37% and the state government 53%. Well, does that matter? Well, if you are running a public hospital, you are the chief administrator of a public hospital, you are asked to administer a service which is a multi-million-dollar service, but you're not sure of your income. Principally, you're not sure of your income because state governments tend to vary the budget with very little notice. And I've said state governments, I'm not involved in which particular state government. This is historically true of all state governments. The state budget into public hospitals will vary year to year with short notice for the hospital administrators. The federal money, on the other hand, tends to come on the basis of healthcare agreements, which are set down for a 5-year period. So we're running our public hospitals with variable financing, and the administrators are not sure of where the next dollar is coming from. So we have these issues of budget. We have other issues of should the public and private sectors be amalgamated in some way. And the previous state government was doing that very seriously and advertising a guarantee of no waiting time. And that was being achieved by using the private sector when people weren't being treated surgically within the times that had been set down. That does work, but it's very expensive. Waiting time and such things as the waiting list for the waiting list, these are serious matters that won't be resolved by politicking. The only way they're going to resolve, or we as a community will resolve waiting times in public hospitals, is to actually let the hospital have some input into the primary care, in other words, the general practice within their area of service. At the moment, the hospitals have no control over primary care. That means the general practitioner can send a patient to the hospital with all the good intentions, but the problem is the hospital has no say as to who's coming and who's not, and the hospital has no idea of how many are going to come. If the hospital had input into the primary care and the decision-making process of who needs to be referred to the hospital, the planning would be a lot better, a lot more smooth, and the waiting list for the waiting list would actually be probably overcome. I move on through my list, and I need to move because I'm going to get the gong when I don't. The training and standards. Politicians really upset people like me when I hear them talk about we're limiting the number of trainees because we're interested in our incomes. And what we're truly interested in is the standards of the training. And we have to do the training, and we are responsible for maintaining standards. Politicians in the past have decided we needed more medical graduates, and we're now facing a tsunami of medical graduates looking for training. We just don't have the training positions. So now we're confronted with doctors wanting to be trained in surgery, but we don't have the training positions to do it, and those people will never be trained in a surgical occupation. So we have manpower issues. We have issues also, though, that junior staff have got awards and regulations and how they can be employed. When I was a young trainee, I had nothing to work 100 hours a week and not worry about it because I was getting the experience. Now that's all illegal, and so we can't train the young because we have to actually keep their working hours within limits that don't actually help the training. So we have issues in terms of how we're going to keep training and maintain award hours, and the two of them are just not going to meet. Training issues move on into regional services. People just don't want to go to provincial cities. Recruitment for provincial city hospitals has been poorly done by state governments in the past. They don't seem to understand that if you want to recruit someone to go to a provincial city, you need to recruit the doctor and his spouse. He's not going to go, or she's not going to go on her own. The conditions of employment in the provincial city hospitals are nothing like what you experience in a city like Brisbane. I've been a urologist in a major hospital in Brisbane for many years. I don't have to go in at night very often because I have trained junior staff to cope with the work out of hours. But if I was to go and work on my own in a provincial city hospital, I'd be on call every night. And it'd be minor stuff, and it'd just drive you mad. So people burn out and leave very quickly. We need to understand recruiting and keeping people in provincial city hospitals requires some skill that state governments and Queensland Health in the past have just not appreciated. And finally, Graham, can I just spend a minute talking about research, a subject that the community just doesn't seem to grasp. Can I say every year we have a federal budget, and perhaps federal budget night's not the most exciting night for you on an annual calendar, but the last federal budget, there was a very exciting statement, and that was the concept of developing a medical research future fund. My profession, sadly, doesn't seem to understand that an opportunity is just going through the keeper and we're missing it. And the community doesn't understand either, I don't believe, the need for medical research to be financed by public money. Can I just illustrate a few points? Public money for medical research is essential. We need research that does not depend on profit return. I'm now talking about antibiotics. The multi-resistant organisms that are travelling the world today is actually quite frightening. And if we don't develop new antibiotics, there's going to be some real problems in terms of infections in surgery and infections in everyday life that we won't be in a position to adequately treat. Now, private research organisations are not interested in developing new antibiotics because antibiotics tend to have a limited time span in terms of their effectiveness, and so the return on the investment is limited. So private enterprise would rather develop new drugs treating malignancy, where the return is likely to be beneficial financially. So public money is needed to treat and develop new antibiotics because that sort of work is not driven by profit. We already know that institutions, major hospitals that do spend time in research do tend to have better health outcomes and are more efficient. International collaboration is required in terms of global research, and this country just can't cooperate with such programs unless they're actually investing in research themselves. So research will give you improvements in the health system. Decreased costs can come from such research where we look at how we should actually spend our money, where should we treat in terms of what pathology and what tests should we be doing to define the pathology. Research will develop new drugs, new devices, new diagnostic tools. We will miss this opportunity if we don't grab the opportunity of having a $20 billion research fund. Finally, I'll say, in the presence of economists and businessmen, research in medical research does give the opportunity of new jobs, new business opportunities, and opportunities for high technology export. We already have an export industry of about $4 billion. That could be expanded dramatically with a $20 billion medical research future fund. Thanks very much.
Okay, thanks for that, Ross. So this is the question-answer statement time of the evening. If I could get someone